All right, well, the lights.
He'll take care of them.
Okay. And, all right. So this is a talk I gave last year, and so I thought it was still relatively pertinent. Is Jennifer here? I hijacked some of the slides from her. And so I was asked to do this at another institution to look at quality issues. So, if you asked me a few years ago if I'd talk about quality, I'd be like, I don't understand what quality is. And I know what the word is, but like, it doesn't really mean a lot to me. I thought it was a bunch of BS until you get in the middle of this for whether it's a program issue or specifically, I spent 2 years on MPSC, and quality becomes something you have to live with when you're on MPSC. And then when you're running a program, it's something you better endorse because you either come to endorse it or you have to by virtue of what happens. So kind of what is quality? And it's like I kind of tried to figure this out, and I didn't really come across anything that could tell me exactly what it is. So I found all these quotes, and I actually kind of like the one that was, it means doing the right thing when nobody's looking. And so there's a variety of different ways to define it, and I think everybody can come across their own definition of what they think it is or what they don't want it to be or what they want it to be. But there's a variety of different ways. And then you may have heard of this TQM, which is Total Quality Management, and you can see kind of what it may encompass, which is really this holistic approach to making things better. Customer focus. So TQM can be, in organizations, medical, non-medical, and a variety of different things. And it's really based on processes and how we make things better. And so we'll go through some of that stuff and specifically how it relates to, now I'm stuck. Whoa, now we're dead.
Hold on. We'll come back. Side buttons should.
Is that where I was?
I don't know.
Go back. All right.
Okay, now tries.
Does that work? Okay, great. So here we were. And so quality measures, Society of Thoracic Surgery has all these things. And general surgery, I'll show you, is coming across a lot of the stuff. The American College of Surgeons is really pushing this quality assurance process too. So actually, the thoracic guys are ahead of this, and they started doing this a number of years back and measuring all these metrics in terms of, if you remember or if you're aware of it, like cardiac surgery has been looked at in terms of outcomes for quite a while. And so they're really careful about what they do. Not that we're not, but they were being measured a long time ago. Transplant's been measured for a long time, but it's only been in the last probably 5 or 10 years at the very most where we've been really assessed in terms of our outcomes in a constructive way. Sometimes people feel it's punitive. So when we look at CQI, so continuous quality improvement, and there's a variety of different, I just have all these pictures here that it's really looking at kind of, if you notice what a lot of these look like, they're all circles. So we identify a problem, we assess it, we make an implementation, then we measure it. And that's kind of what the continuous process improvement really is. And there's a lot of different, you go through like on the web and you get all these different things, and it's a lot of mumbo jumbo, but to me it's all basically a circle. And so I think that's how I look at it in a very simplistic way. I guess you can get really into it, which I consider myself not into it, so I'm not an expert on it. And so I try to make it simple. And so I think that plan, do, add, check, act is a good way to look at it, the way we look at things. So I try to simplify it down into what I thought was a continuous improvement for transplant. So we look at a patient to list them. So how suitable are they? Then we may transplant that patient. Then we have to follow them up. And so that involves the care and follow-up. And we're going to discuss some of the stuff, how we implement it. And then what happens to the patient is really important, not just for the patient, but for the program. And so that's important also in the data, and we'll talk about that, and we evaluate that in the context of how the patient does. UNOS oversees that, and then we get regulated by the government based on what happens to not just that patient, but the program. So all these things come into play with our risk assessment, our tracking, adjustments, oversight, and then the systems that we have in place. As I mentioned, the American College of Surgeons now has this risk assessment. I don't know if anybody's seen this, but it's actually on the website, and you can plug in all these things for a patient who's undergoing a general surgical procedure, and they'll give you the associated risk with that patient. And so this is actually Thomas Hamilton's the guy who kind of oversees a lot of the stuff for transplant for CMS. And so I thought this was interesting. I think Jennifer gave me this slide. Programs with these are transplant programs now, persistently problematic outcomes. And you read through this, it's pretty interesting. Limited QI ability, unskilled at using data, the SRTR data, unaddressed issues, personal limitations, lack of protocols and adherence, which is really important, weak or non-existent multidisciplinary teams, frequent confabulation manifested as explanations that are logical but not real, which I always find interesting, meaning we explain the bad things away, and unexamined beliefs as to causes. So it's the patient's problem that they didn't do well. So I thought that was kind of interesting. And so who listed this guy? I think we've been through this process in this program, so this is not for us anything new. And we've done all this, and why didn't we know? And he can't say no to anybody. I mean, we can all, we've all been there. We still are there almost every day when we do this. And what we can't do is stick our head in the sand, because you do that and you won't be able to help any patients because you'll be put out of business, just the way the process works. So why are we regulated? The Government Accountability Office reported that programs are not adequately regulated. This is back in 2005, which led to a lot of implementation, really, of regulations. Now, some of these regulations were already in place and weren't being enforced, but CMS then issued all these conditions of participation, which really, and then interpretive guidelines for the surveyors, which really set the ball in motion for not only the implementation of the regulations, but the oversight and then the authority to really crack down on programs that were not performing well. And so if you look at oversight of your organization, a lot of this stuff comes into play. And then really with transplant, this is really true, okay? So we're probably one of the, if not the most regulated area in medicine currently. And you can see, so here are the centers, and we have to report to UNOS, who gets the data from the SRTR. UNOS has a board of directors, has committees, and then the Department of Transplantation, which goes up through HRSA to HHS, and then CMS comes down on transplant centers as well. So there's a lot of different organizations that are in play overlooking regulations. But the regulations are important because it's, what we do in transplant is really predicated on public trust, right? So if patients don't and families don't donate organs, we're out of business. And when patients and families donate organs, they trust that we use those organs to the best of our ability and the best use of those organs for patients. And that's, a pretty broad statement, what's the best use, and everybody has their own particular interpretation, but that's why we have regulations and policies in place. And so it's really important that we, as physicians, understand that we are really beholden to the public for our ability to do what we do, and so we must really obey those laws. And obviously Medicare is the biggest payer for transplant, and so they can exert a lot of leverage, and they do through CMS. So you may have heard about these program-specific reports. They come out by the SRTR every 6 months. I'll show you a copy of them, but they're really important for programs. They use a cohort of patients. They were mandated by the NOTA, which is the National Organ Transplant Act, way back when, and they're really designed for programs to look at their outcomes. Now, they've been taken completely out of context, in my opinion, and I think most people's opinion, now used by third-party payers very aggressively to look at programs and their performance, and whether you meet certain metrics to be put into their centers of excellence and whatnot. They're used by CMS, which they need to be. They're used by your competitors to market against you, and they're used by our own programs to market for us. And so all those unintended consequences, I think, came as a product of these PSRs, and you can't change that at this point. So this is what a PSR looks like. They come in different forms now. There's an old form and a new form. This is an old form, and it just gives you all this information. And the most important thing that we look at is really what is your patient survival, which is right here. So what is your observed patient survival? What's your expected patient survival? So this actually was our liver program a few years ago. And so our observed was 84.7%, and our expected was 87%. So that's 1 year patient survival, and it's considerably different now. In the last PSR, it's more than 10 points over. The observed is more than 10 points higher, and it's about 7 points over the expected. So expected really is a risk-adjusted, what should it be based on your patient variables. And we'll go over that in a little bit with data. So anyway, this is just, and then they'll tell you if it's different, if it is or isn't different. And so that's just kind of what a PSR looks like. Now, UNOS is made up of a lot of committees, and the one we're just going to talk about briefly is MPSC. Jennifer's talked here before about MPSC, and I'm not going to reiterate a lot of that, but I have a few slides that she shared with me. And they have the ability, or it's not the ability, they have the authority, and that's one of their main missions, to oversee quality of programs. And one of those quality metrics is outcomes. So programs are evaluated every 6 months, and they're based on 1 year patient and graft survival, and they're 30-month cohorts, and they lag considerably. So that's one of the problems, is if you have problems 3 years ago, they now show up now. And I'll show you some other information that gives us more real-time evaluation of programs. And so they look at 3 different things, really: the magnitude of the problem, which is what is the observed minus your expected events, and the events is patient death or graft survival, which is probably more important, or more, when you look at kidney transplants, well, it's patient survival, but it's also graft survival. And liver, graft, and patient survival aren't that much different. Now, what is the significance? So the standard mortality ratio, which is the O to E ratio, and then is it statistically different? And so if a program can get flagged if all 3 of these things are observed. When they get flagged, that means that they get really put under the microscope in a big way. And that is not what you want to have happen to your program. But like I said, about 10 to 15% of programs get flagged on almost every cycle. So the MPSC is a peer-reviewed system. So UNOS is made up of us. When people talk about UNOS, it drives me crazy, and I've been involved with them for a long time, when people say UNOS is trying to do this. Well, that's not really true. UNOS does have, it is a corporation, and they do have people that are employed full-time as UNOS employees, but they're like policy analysts and research people. They're not the ones making policy. Policy is made by people like us. I mean, you go to a UNOS committee, and they're made up of physicians and lay people and patients, and those are the people that make policy. Then it goes up through this process up to the board, which may approve or not approve. So UNOS is the community. The community makes the policies in which we live. MPSC is one of those communities. It is a peer-reviewed process that we look at each other in a very confidential way. You can't disclose any of that information about programs, and a lot of it's blinded, that you don't know the program unless they come in front of you for an interview or a hearing, and that is a confidential process as well. It's self-regulated. Like I said, we regulate ourselves. And it maintains standards and improves programs. So we're really there to help programs. I just rolled off that committee earlier this year, and it is really educational to be on that. And if you have the chance to be on it, it's highly recommended to do it. It's a fairly heavy workload, but it's really good. There's 2 subcommittees of this. The PACE, which is the Performance Analysis Committee. They look at program performance, their outcomes, things that we just talked about. And then the PCSC, which is the Policy Committee, where they look at all the ramifications of policies and infractions, and that there's a lot of that stuff. And that I served on that for 2 years. It's very interesting to see what you think isn't a problem, and it becomes a problem, and you come back and you say, wow, I didn't know that could happen. And you go to your program and you say, make sure we do this, this, this. And it's really very enlightening. So it comes down to all different OPO issues. OPOs come under the same jurisdiction as the centers do. They get ratcheted down on pretty heavily as well. And center issues, I mean, there's just a million, transplanting the wrong kidney, the liver went to the wrong patient. There's just a million things that you see when you rotate through here, because there's a lot of programs and just stuff happens. It's really an interesting, enlightening experience. And then it just shows you what we can do from MPSC. So these things are things that we hand out specifically with NUV, Notice of Uncontested Violation. We hand those out frequently. So if a program has a policy infraction, we usually give them an NUV, which means you violate your policy, you get a Notice of Uncontested Violation. We don't allow programs just to violate a policy and get away with it. Otherwise, there's no reason to have the policy. And so there has to be a ramification for each policy infraction. It doesn't really mean that much unless you have a bunch of NUVs, and then you may get a letter of warning, and then it gets escalated. It also depends upon the level of infraction of the policy. If it's a really flagrant violation, we may just give you a letter of reprimand up front. When you get to this point where these things are very serious, and usually when you get member on probation or a member not in good standing, we may say to them, and those sometimes are really serious infractions or ongoing problems in a program that just they're sustained despite oversight from the MPSC, and we'll tell them, look, you guys are in big problem here, you better get your crap together, and they don't, or they refuse to, and we send on-site peer teams to help them, and they still can't get it together. They refuse to. They're not enough insight. They stick their head in the sand. And so we threaten them with these things, and then usually that will bring them scared straight. The hospital gets involved. When I was there, we had a number of hearings, and you do not want to be at a hearing for MPSC. It is a legal process. The lawyers are there. It is a very sphincter tightening experience. I have not been on that side. I've been on the other side. I have sat through at least a half a dozen hearings with programs. Some were friends of mine on the other side. But it is a very intense process. And you get the whole hospital shows up, like the CEO of the hospital. I mean, it's really not something you want to do. So there's a lot of power invested in the MPSC. And if we did recommend one of these actions, that it goes to a hearing, and then it can go up to the board of directors, which ultimately has to sanction whatever is recommended by the MPSC. So anyway, benefits to the volunteer scare you straight, and it sure does. You become very knowledgeable of the policies. You have to, and exposed to best practices and worst practices. So it's really a great experience. And then quickly through CMS can then come down on a program as well, and you can go up this whole escalation of things to if you had 2 subsequent reporting episodes where you've been flagged twice in a row, then you're in deep trouble. And CMS will come in and say, you have a big problem. We're going to put you in an SIA, which I'll show you in a second, a system improvement agreement, unless you can prove to us that there's a problem that's been addressed already and you can apply for what's called mitigating factors. And so of what I found of the mitigating factor requests, some were agreed to because they were able to show, for instance, that they had really good QAPI programs and they've addressed their issues which led to the problems, already, and so they gave them what's called mitigating factors, so they don't put them in an SIA. But about a third of the programs get put into an SIA, System Improvement Agreement, which is something you do not want to be in either. We have not, fortunately, had to do this here, but I know programs that have, and it's usually isolated to a organ system, so not the entire transplant program, but you could have a specific organ system that's in an SIA. And those are really to promote better compliance with the COP, condition of participation. And if you don't get up to speed with your SIA, and it goes for a year, they can revoke Medicare funding to the hospital. So it's a very serious thing. And they have a tremendous amount of leverage. And parts of an SIA, really, you have to notify all the patients on the waiting list for that organ that you're in an SIA. There's an on-site external peer review process that goes on for the whole year. And they're there for, I can't remember exactly, but it's not insignificant. There's somebody on site there for, it's like 10 days a month or something. There's a lot. And then all this other stuff you can see that has to happen. But it's a very intensive process. It's very expensive. It can cost the program hundreds of thousands of dollars to be in an SIA. And what happens, I found this that shows that mitigating factors, what happens when you get an SIA or mitigating factors is these are programs that were in SIAs or MFs, and actually this is mortality. Their mortalities come down when they get put into a system improvement. So actually they're doing what they're supposed to, so they're improving their outcomes. But usually, and this shows the same thing that with kidney, liver, and heart, that when you get into an SIA, or when the COPs have been implemented, it improves the outcomes, which is really what it's supposed to do. As I said in the beginning, we're predicated on the public trust to use these organs. This just shows that programs that get put into SIAs, this is for kidney, that what happens is they become more conservative and their volumes drop off considerably. So they have, you kind of expect that. They have to become, at the ratchet it back, they become more conservative to get their survivals higher, so they're no longer in trouble. So data, we talked briefly about in the beginning. So garbage in and garbage out is a pretty important concept. We found this out kind of the hard way, and I think a lot of programs did, is that if you don't have a good, robust data integrity process, you can live and die by your data. So what happened to us, it was a while back, like 5 or 6 years ago on the liver side, was our outcomes were about the same every year, but what happened, we didn't notice this, but our expecteds were going higher and higher, and eventually that difference became significant, and we didn't even realize that what was happening. And then that generated this really intensive data integrity process where we cleaned up a lot of our data. It's a very robust process. But you own it. Whatever you put in, that's yours. And if you put in poor data, you get poor results, which doesn't necessarily reflect your expected outcomes. So it's really important that you have this. And I think in our programs now, we all have a pretty robust process of getting our data not only in, but the integrity of the data is really important. So the risk mitigation, so it starts with our ability to put in good data. You break it, you fix it. We found that out. And so having responsibility is really important. So it can't be like, well, that wasn't my job or that was somebody else's job. There has to be an element of responsibility for who is in charge of this data and to be able to QA that process to ensure that that integrity happens consistently, even when nobody's looking, like we said in the beginning. So defining responsibilities, define your variables. So we went through this too. So what is life support? Dr. Speg argued for a long time that life support is almost anything we do. So TPN is life support. You can argue one way or the other, but I think it's important that programs define what their variables are if they're not already defined for us by the SRTR. You define it and you implement it, and then you consistently apply that across all of your data elements. and defining your source documents, and then QA the process. I think we talked about a lot of this stuff. Functional status came up by virtue of a hearing when I was at MPSC and realizing like how, well, I already knew how important it was, but we came back and with Tricia's help and Vanessa's help, we put in this functional status process with liver, which is really important, and I'll show you because of the impact it has on our expected outcomes. The functional status of a patient is really, really important. So we put in this really defined process that you can't interpret it. You get asked, the coordinators go through and ask every one of these questions of a patient, and it gives you what the functional status is, if it's a yes or a no. And it gets put into Sunrise, and that's what gets put into the SRTR. And because the importance of functional status in terms of expecting your outcome, so if you have a really sick patient, their functional status and what they call this Karnofsky score is really low, it impacts our expected survival. It brings it down a lot, so it's really important. So we talk about risk adjustment in that regard. This is maybe somebody from Texas trying to fix this car, but so risk adjustment is what would be expected for the patients at that center if they had outcomes comparable to national experience. So everybody says, oh yeah, we transplant sick patients. Everybody does, right? So I mean, everybody says that, but you know, there's certain ways to measure how sick people are. And so they need to be adjusted for a variety of factors, and whether it's kidney, liver, or anything else, there's all these factors that go into risk adjustment in terms of expecting outcome. So I mentioned how you predict what it should be. These are some of the variables that go in, and then these things here are called the beta values. So when they're high, so these are high, the ones I highlighted. And so when they're high, that means they have a high impact on your expected outcomes. So those are things you really need to pay attention to. And for instance, I don't think it was on here, but so if they have patients on life support, they have a really high beta value. The Karnofsky score, or the functional status of the patient, is really important as well. I can't remember if it was in here or not. Yeah, here it is. Functional status is really high, the impact value. So we pay very close attention to those high beta values and make sure that those are captured and put in accurately on every patient. And so the risk adjustment matters. I don't want to, for the sake of time, go through this in detail, but it really just shows that if you have a low volume program and you have a few events, you can have statistically different outcomes. If you have a high volume program with a few events, it's not going to really change things. So volume is important in terms of that. So these are some of the other things. These were in kidney let's see. So as I mentioned previously, when you start looking at, so if your outcomes are subpar and you start trying to figure out kind of what's going on, the natural response is, well, we need to do less sick patients. You do less sick patients, you're going to do less transplants. I mean, I think that's pretty intuitive. It's not like our outcomes are poor, we're going to do more transplants. That's not the typical response. I think if you get into trouble, it's usually because more often than not, you're transplanting patients that the risk is not captured well, or the patients are too risky. We go through this every single day when we look at how, you know, anybody who's been on rounds with this, you know, which patient is too risky, which isn't, you know, which patient is justified for any individual time in the program. It's a dynamic process. And so creating these systems and processes is really important. And I think quality, you know, like I said in the beginning, I am not a quality guru, but I do believe that quality is a culture. It's not like this word, it's not like this thing you do. It's like something you think about, and it's actually something that I've had to really adopt over the last 5 years or so, to think about from a quality mindset, what does that mean? And I've come to really think of it and respect the fact that it's a culture. It's not like, okay, you have a quality nurse or you have a quality person. Quality should be something that happens on a daily basis around the entire organization. And it's really something that has to start either top down, bottom up, any way you have it, but everybody has to buy into the quality issue. And so when you get into a problem, then you have to be brought into compliance, right? So the first stage of compliance is denial, right? Say, well, that's not our problem, or that, that guy should never have been transplanted, or Dr. So-and-so wanted to do that, and, that's why we're in a problem. That's denial. And then you get angry because you're being sanctioned by MPSC or whatever it is, and you say, that's ridiculous, how can they do that to us? And then you start to try to negotiate with them, saying, well, if we do this, will you let us, open the program up or do whatever, and you can't negotiate with MPSC because it's not a negotiable entity. They tell you what to do, and you either do it or you get out of business. And then you get depressed about it, and you say, I don't know what I'm going to do, and then you accept it, and then you move on to the process improvement and the quality aspects. So, I think these are really important, and anybody who's been through this process can probably sympathize with that. And so it really is a quality culture that starts where the problems are pathologic and covered up, all the way to you become not a reactive process where you're reacting to an event or something that happened to your program, but you become proactive, where you're anticipating things before they even happen, so you prevent them from happening in the first place, by and large. So that's really this whole spectrum of what happens in a really mature quality QAPI process, is anticipating and preventing it before it happens in the first place. And so that's just kind of what this is. And so the process development, I think we've already been through a lot of this already. Identifying key stakeholders is really important. It doesn't mean that person is the one who's responsible for the entire process, but there need to be people that drive the quality process. So a quality person is, not the only one who's going to do it, but that's the person who sets the stage and the tone. Accountability is vital. We all have to be accountable for our actions. And then follow-up. If something happens, what do we do about it? Root cause analysis is important, and lean concepts. Trisha's the lean queen here, right? So you guys are all leaned out. And then decisions at listing and discharge. And it's not just at listing, because we know that we're being measured currently on our one-year outcomes. So yeah, we can get the patient through, we decide to transplant them, we transplant them, surgery goes well or relatively well, and the patient gets discharged. That happens pretty frequently in a pretty good process, but then it's really that part from discharge to 1 year, which is something that we've had to focus on pretty intensely over the last few years. And we've done a lot of these things to really look at that. And that discharge planning and follow-through is really important. So some of the things that we looked at were, this actually is Zin management, where they're able to predict what our outcomes are. So if you just take one of these, so these are the confidence intervals. So if you fall within these, you're doing okay. The orange bar is what the observed is, and the expected is this is what the expected survival is. So if you start down here, if you start up here, we can see that over time, our expecteds had, our observed had fallen down. But anyway, you can get an idea of they can predict out your cohorts, which is really helpful when we look at things. And then we also implemented this outcomes tracking projection that Margie does, where we can look at our rolling daily cohort. So I said it's a 2.5-year cohort. So we can look at any one day and see what the survival is, or the predicted survival is for those patients. And we do this pretty routinely in the liver side. We'll sit down every few months and we'll look at patients that are in that cohort, who are the ones that are at risk for problems. And then outcomes, these are just a reflection of that. CUSUM is something that's new, cumulative sum technique, and it's generated by the SRTR. It kind of gives you a real-time projection of what's going on. And it uses these 3-year cohorts, but it's really much more relevant. It's newer, up to the last 2 months. So it can really look at things very close to real time. And so this is just off the SRTR website. So this is like a typical CUSUM. I'll show you our most recent CUSUM curves on the next slide. But when the CUSUMs are going up like this, then it's higher event rates. So there's more graft or patient deaths. When it's going down, there's fewer event rates. So it's good for things to go down. When things are going up, you may need to be more concerned about it. So this actually was our most recent liver CUSUMs, and you can see we had some events back in 2012 where it went up, but then for a long time went way down. So this is where you get into trouble above this line. So we had a few events at the end of last year, and we're way down here. So we're in pretty good shape because the CUSUMs are heading down, and this is almost real time. So it's really helpful. I mean, I knew this because I keep track of everything on almost every patient. I kind of know who the problems are. We do this all the time. So it's really important. That helps, I think, for us to then gauge where we are programmatically real time in terms of what is our risk tolerance at any one day, and it depends on the day. So if we see that we've had some events recently which might be dragging down our survival, we might be a little bit more cautious about going out on a limb for a riskier patient. And in that time, we might say, well, that patient's really not a good transplant candidate. Whereas a year ago, maybe we might have been willing to take a little bit more risk. So it is a dynamic process. And it's really important to know where you are for your program at any one time. So review programs, so these guys do this high MELD review, and we do it with the physicians and the nurses as well when we look at what's going on. And so we have a lot of these things that go on pretty routinely here. And we have, not most importantly, but one of the important things is we have this dedicated one-year team. So Tom and Mark aren't here, but every 2 months we sit down with them and we go over all the patients that are in the one-year cohort. And we identify those patients that are at risk. We identify patients who haven't been followed up in the last month. We mandate that the patients be seen at least once a month for the first year. And if they haven't been, then Tambi gets on the phone and calls them up, finds out what's going on. And in the past, we didn't do that. So, patients, sometimes they didn't show up for clinic, and they would kind of get lost in the follow-up, and we didn't track them down, and the next thing we know, they were dead. And so that's kind of what, one of the things that we did, which was really helpful, was really instituting this intensive one-year follow-up. This just better patient population, better follow-up, better professional development, better systems, and everyone has to be involved with it. As I said, the American College of Surgeons has done this they're really into this whole quality stuff, but I think it's really important where the physicians and the surgeons really have to be on board with this. Because if you have an organization and you don't have the physicians on board, you're like button heads. And I think that's what's happened in the past up until when UNOS and CMS had the authority and started really cracking down on programs. 10 years ago, they would say, you have a problem, and you would say, yeah, we'll deal with it. Now, nobody wants to get a letter from the MPSC. I mean, you're like threatened by these things because they have tremendous authority to really change the context of your program in a positive way. And they're not trying to be punitive. They might want to make things better. So I think it's also important to recognize you get what you measure. So if we say we're going to measure one-year patient survival, that's the things that programs are going to work towards. If they said we're going to measure 5-year patient survival, it would probably change how we did things. If you're going to measure, whatever, people respond to what you measure. So one of the things that's actually coming out for public comment is this thing called pre-transplant metrics. So they're going to be looking at the way we take care of patients on the waiting list. What's the mortality they have this whole thing they can measure. What is your mortality on the waiting list? And a bunch of other things. What is your chance of getting a transplant? And so they have this whole thing called a CPM. I don't think it's good, but I was involved in the process. I think it's a problem. We're going to get squeezed at both ends. So it's going to totally change if it gets past how we list patients, whether we do or don't list them. And risk adjustment's really important, as I said, that you got to know what your data is, and all the PSRs, all the information gets used. It just drives things. I think it's probably driven things to such a high level of performance and outcomes these days that now the bar is so high. if you look at 1-year kidney graft survival, it's like 97%. And if it's 95%, you may get flagged if you have a high volume program just for a 2%. I mean, that's like incredible, those results. Liver survival in the United States 1 year across the board is like 91%. And that's phenomenal. And that's for everybody. And we're not going to make it any better. But so if you have 88% and you have a decent volume program, you might get flagged. I mean, that's still great patient survival. So I don't know. It's like a train. It's like a train on a track that's unstoppable. Is where do we shouldn't be trying to penalize programs because they have 88 versus 91% survival. We want everybody to perform at a high level. The way it's set up, almost 10% of programs are always going to be flagged, which I think is a problem. So I mentioned this briefly. So connecting quality to transplant institutional quality committee. So quality should start at the grassroots, flow up through the programs, flow up through the hospital. And so everything should be integrated into a quality culture. I think that's really important. So some of the lessons, at least that I took away from the process that we went through, was we need to have robust quality. It's really important to have that circular process where you anticipate and fix problems before they happen. If they happen, you identify them and put in place systems that prevent them from happening again. Strong systems and data integrity is imperative. You can fight the regulations, but that's a waste of time. If you can't control it, don't fight it. You need to have institutional support, meaning the hospital needs to buy into this. The programs, not all, but a lot of the programs I saw come for MPSC were these small programs that weren't doing a lot of transplants, and they were like, I don't want to say token things in the hospital, but it wasn't, the hospital didn't take these things seriously. They got into some problems, they weren't investing in the program, then the hospital will have to make a determination as to, do I want to have this program or do I not? And usually if they did, they'd have to pour a lot of money into it and hire a lot of people, and not physicians really, but the support staff to really structure it and make it perform well. So if you don't have it becomes clear when the institution is not involved in the program. I say quality at all levels, and transplant is the ultimate team sport. I think that's the end. So I'm not a quality guy, but that's a quality talk, and I do believe in it now. I mean, you had to drag me along a little bit, but now I totally endorse it. So, any questions? All right.